Good day, LU4 students. I'm Dr. Cecil Jimeno, and the topic that we will discuss is glucocorticoids and mineralocorticoids. This is the first in a set of 3 lectures. This first slide set will be focusing on a review of physiology and a little bit of biochemistry. The second slide set will focus on the pharmacology of the glucocorticoids and is probably the main and most important slide set, while the third slide set should be viewed in the immunology module and to a certain extent the respiratory pathology module. Now, this discussion on glucocorticoids and mineralocorticoids is probably the first in a series of lectures about drugs that have systemic effects. Now, this is the entire scope of the lecture. We will talk about corticosteroid agonists and antagonists. However, the antagonists will be, the lecture on antagonists will be found on the second slide set, but it comprises a very small part of this entire topic and have been included for completion, but in terms of therapeutic use, there are not too many. So the main drugs that we'll really talk about will then be the glucocorticoids and the mineralocorticoids, the agonists. So this is the outline of the discussion, only 3 bullet points. First is a review of physiology and biochemistry of normal endogenous glucocorticoid biosynthesis. And then we'll go through the kinetics, how are they metabolized and excreted. And then we'll end with dynamics or the physiologic effects, which will be reprised in the lecture on pharmacology because it's these same physiologic effects which you will then find in the synthetic glucocorticoids, the agonists. Okay, so you all know that the adrenal gland is divided into 2 main parts, the cortex and the medulla. In the medulla are secreted the catecholamines, norepinephrine and epinephrine. And in the cortex, of course, the corticosteroids, of which you have glucocorticoids, mineralocorticoids, and androgens. We take note that the glucocorticoids and the mineralocorticoids are both 21 are both having 21 carbons, and therefore they would share similarity in structure, and that's also the reason why in terms of acting on their receptors, there is some lack of specificity in terms of occupying each other's receptors. You also all know that cholesterol is the main precursor for the synthesis of endogenous steroid. Strictly speaking, all products that are derived from cholesterol are actually steroids, including vitamin D. But typically, the term steroid is usually and loosely used to refer to cortisol and the glucocorticoids. In this lecture, we'll talk about both the mineralocorticoids and the glucocorticoids. So this is the outline of the major biosynthetic pathways for the adrenocortical hormones. Now, again, this is cholesterol, the main precursor, and through a series of enzymatic steps, cholesterol is transformed in this mineralocorticoid pathway into the final secretory product, which is aldosterone, the main mineralocorticoid. And then in the glucocorticoid pathway, again, several enzymatic steps with cortisol as the main hormone of the pathway. And finally, the androgen and estrogen pathway, where testosterone, of course, is the main androgen, and it's converted into estradiol in the peripheral tissue, mainly in the adipose. If you then take a look at our endogenous cortisol, you can see that its pharmacologic or synthetic equivalent is hydrocortisone. So you can see the structure of cortisol and the structure of hydrocortisone. These are the other synthetic glucocorticoids, And you can see that for the most part, they share similarities with the basic structure of cortisol. But here, you notice the fluorination of that basic structure. And so these are the fluorinated derivatives, triamcinolone, dexamethasone, and beta-methasone. And here, on the other hand, is aldosterone. So we'll begin our discussion with the mineralocorticoids, focusing on aldosterone and its pharmacologic equivalent, fludrocortisone. In physiology, you already know that aldosterone acts at the distal convoluted tubule to promote sodium reabsorption and potassium excretion. So sodium is reabsorbed, potassium is excreted. And this secretion is controlled by the renin-angiotensin and aldosterone system, while ACTH is only secondary. Versus for the glucocorticoids, ACTH is the primary control. Now, like I have emphasized earlier, the receptors for the mineralocorticoid actually have the same affinity for glucocorticoids as its endogenous ligand, mineralocorticoid, so that many of the glucocorticoids can actually occupy the receptors of the mineralocorticoid and exert the same effects. And that's why when we talk about glucocorticoids, we talk about not only their glucocorticoid potentiality, but their mineralocorticoid potential or effects. Now, when aldosterone excess, this is what happens, such as in primary hyperaldosteronism or various disease conditions where aldosterone is high, sodium reabsorption or retention is promoted, which can lead to hypertension, edema, and cardiac failure, and potassium secretion causing hypokalemia, which can manifest as muscle weakness and metabolic alkalosis. So that's what happens when there is an excess of your mineralocorticoids. Now, on the other hand, if you are lacking mineralocorticoids, if you lack aldosterone for a reason, let's say you've had bilateral adrenal TB, you've had adrenocortical cancer, and both adrenals have had to be removed, or an autoimmune disease, for example, like Addison's, so that the cortex is unable to make the mineralocorticoid aldosterone. The pharmacologic replacement is called fludrocortisone. In fact, fludrocortisone has both glucocorticoid and mineralocorticoid activity. But in these very small doses, this drug has very potent salt-retaining activity, but the dose is too little to have any anti-inflammatory or glucocorticoid effects. And so it's given for the treatment of adrenal insufficiency of various causes, like I've already mentioned. So we move on to the glucocorticoids, and briefly we'll review its physiology. We know that the main endogenous glucocorticoid is cortisol, and its concentration increases during stress. It has metabolic, anti-inflammatory, and immunosuppressive effects. And it has this permissive effect on the catecholamines, so that the main effect of the catecholamines, which is vasoconstriction of the blood vessels, is reinforced whenever cortisol is present. And you will realize later on that this is very important in anaphylaxis or in the shock or anaphylactic shock due to intake maybe of certain foods or chemicals to which you are allergic to. This leads to vasodilatation, and the main treatment is actually epinephrine. But we should give corticosteroids along with epinephrine because the glucocorticoids reinforce the vasoconstricting effects of the catecholamines. The average secretion of cortisol is as given, but I will go to that in the next slide. It is better to just state it in the number of milligrams that is actually secreted daily. The control is via the hypothalamic pituitary axis through the adrenocorticotropin hormone, and it follows a 24-hour biologic or circadian rhythm with the highest plasma concentration in the morning. Because of their specific action on glucose metabolism, cortisol and its natural and synthetic analogs are called glucocorticoids. In the normal average adult, in the absence of stress, how much cortisol is actually secreted per day. It's around 10 to 20 milligrams of cortisol. Now, this number is important to remember because the pharmacologic agonist, hydrocortisone, is actually, even when given per os, no, or oral, has almost 100% bioavailability. So that if you want to give a dose of hydrocortisone, the pharmacologic equivalent, that's equivalent to our endogenous cortisol, it's the same number, 10 to 20 milligrams per day. Physiologic secretion. So the rate of secretion follows a circadian rhythm governed by pulses of ACTH that peak in the early morning hours and after meals. So just to show you, this is cortisol secretion around 10 to 20 milligrams. It's highest in the morning and wanes in the afternoon. While for the mineralocorticoid aldosterone, it's the same. This is the amount that's secreted. And the concentration is the same whether in the morning or in the afternoon. Now, just to show you this circadian rhythm, here is sleep, and this is morning when we wake up. Like I said, the ACTH peaks early in the morning, and this is quickly followed by, after this ACTH surge, it's followed by a cortisol surge. So early in the morning. And it wanes towards noon, and towards the afternoon, it begins to wane. There are pulses, as I said, after we eat, and then it wanes as we prepare to go to sleep, and it dips as we are sleeping. And this dip in the cortisol through negative feedback creates the stimulus for ACTH to be secreted, and the peak of the ACTH secretion is early in the morning. In the plasma, the cortisol is bound to circulating proteins, mainly the corticosteroid binding globulin, or CBG, which is a globulin secreted by the liver, as well as the predominant protein, which is albumin. 90% of the circulating hormone is bound to CBG under normal circumstances, and a smaller 5 to 10% is free or loosely bound to globulin and is free to exert its effect on target cells. When the plasma cortisol level exceeds 20 to 30 microgram per deciliter, so high levels, the CBG is saturated and the concentration of free cortisol rises. So for example, in endogenous hypersecretion of cortisol, let's say of Cushing's disease, a good proportion of the circulating cortisol is free because the capability of CBG to bind cortisol is saturated. Or when you take in or give exogenous steroids at high doses, then you saturate the binding capacity of CBG, and so you have a lot more free hormone to exert its action, whether therapeutic or may lead also to adverse drug effects. These are some circumstances that alter the kinetics of CBG. That includes pregnancy, the use of estrogen, let's say oral contraceptive pills, or hyperthyroidism. And the opposite, when CBG is decreased in hypothyroidism, and in some uncommon genetic defects in synthesis of CBG. Protein deficiency states like malnutrition or chronic liver disease not only decreases albumin but also decreases CBG. And therefore, in these disease states, the protein deficiency states or hypothyroidism, you may expect a more or an exaggerated action of the glucocorticoids. Albumin has a large capacity but a low affinity to cortisol. And so for practical purposes, cortisol bound to albumin should be considered to be free. When you take in synthetic or pharmacologic steroids, they're largely bound to albumin because the CBG is bound, no, to our endogenous cortisol. And the clinical implication, therefore, is that there will be a greater proportion of the synthetic steroids which are going to be unbound or which are going to be free, no, to exert its action, whether, again, therapeutic or negative. Now, moving on to the kinetics of glucocorticoids, its half-life of cortisol itself is quite short at 60 to 90 minutes, but the half-life may be increased when you give it pharmacologically, such as hydrocortisone, when you give it in the loading dose and in stress. No? So endogenously, when you're stressed, there's more cortisol that's being secreted, and so you might expect that the half-life is prolonged. Metabolism of glucocorticoids is in the liver by conjugation with glucuronic acid or by sulfation, and around 1% is excreted unchanged, and the rest are metabolites. Going on to the dynamics or the action of the drug, no? Okay. So what happens, no, when cortisol is acting or exogenous glucocorticoids are acting? They have actions on glucose, protein, fat, and bone mineral metabolism. But their main therapeutic use is really the anti-inflammatory and immunosuppressive action. Both the natural and synthetic steroids act by binding to a specific nuclear receptor that interacts with promoters of and regulate the transcription of target genes. So I know that you remember this from previous discussions of mechanisms of drug action. You've probably talked about nuclear receptors, but just to reprise the action of cortisol, S for steroid, so it's bound to CBG. Its receptor is this glucocorticoid receptor that are primarily cytoplasmic in the absence of the hormone ligand. This glucocorticoid receptor is complex with chaperone proteins, the heat shock protein 70 and 90, and this inhibitory protein. When the free hormone enters from the plasma and interstitial fluid, when it enters the cell, it encounters its receptor in the cytoplasm. And as it binds to the glucocorticoid receptor, it induces a conformational change that allows the receptor to dissociate from the inhibitory protein and the chaperone proteins, the HSP. Subsequently, the steroid glucocorticoid receptor complex translocates to the nucleus. There is dimerization, and the glucocorticoid receptor, one of its domains, intercalates the glucocorticoid response element in the chromatin so that there is a transcription of specific proteins leading to alteration in cellular function. So just taking a look at the specific domains of the glucocorticoid receptor. So this is the protein that is folded. This is the glucocorticoid binding site. This is the binding site of the heat shock proteins. And these are the zinc fingers that would intercalate the chromatin. When there is inflammation, there is histone acetylation of the chromatin, so that in fact there is the production of several mediators of inflammation, such as the cytokines. And in the presence of steroids, there is histone acetylation and gene silencing, conservation of the chromatin, so that you decrease the production of these mediators of inflammation. And to show you the classic model of glucocorticoid action, there are two parts to its action. One is the transrepression here, so that in fact the action of the glucocorticoids will be to decrease the transcription of important mediators of inflammation like cyclooxygenase 2 or cytokines. And on the other hand, transactivation means that there will be specific proteins that will be transcribed, like lipocortin and the beta-2 adrenoceptors, which are very important also in attenuating, or in decreasing the the effects of inflammation. So just to show the specific actions of the glucocorticoids, again, glucocorticoids will induce the lipocortin, and this lipocortin will inhibit the action of phospholipase A2. So again, this is the entire arachidonic acid pathway, where in the presence of inflammation, there will be a disturbance of the phospholipid bilayer. And after disturbing that, there will be the action of phospholipase A2. And this is now the arachidonic acid pathway leading to the production of prostaglandins and prostacyclins and the thromboxanes. When glucocorticoids are present, they will induce the production of lipocortin, which is inhibitory to phospholipase A2. And on the other hand, it will also inhibit the induction of cyclooxygenase. And also, there will be a production of lipomodulin or macrocortin, which again inhibits the action of cyclooxygenase. I've also talked about these physiologic effects already of glucocorticoids, that it increases during, its concentration increases during stress. It has this permissive effect on the catecholamines, so that you can oppose the effects of the immune and inflammatory mediators that decreases the vascular tone. And later on, we'll talk about the metabolic effects. The effects of glucocorticoids on inflammation include the following. There's a decrease in the production of the mediators of inflammation, such as the prostaglandins, cytokines, and interleukins. And it also has cellular effects, for the most part, a decrease in all the white blood cells, except for the neutrophils, which tend to increase, actually, neutrophilia, while the rest will have a decrease in number and function. Again, there are three major mechanisms that account for the anti-inflammatory, immunosuppressive, and the anti-allergic effects of steroids. So steroids are very good in any form of inflammation, autoimmune problems, or allergies. And the reason for that is, first, I've talked about this, the permissive effect on catecholamine activity. Second, the inhibition of the arachidonic acid pathway cascade. And the third is the interference with the leukocyte migration and function. So we'll begin with the effects on the mediators of inflammation. What do the steroids do? They prevent an increase in capillary permeability, decreasing edema. They inhibit chemotactic factors. They interfere with antigen phagocytosis and reduce the adhesion of the macrophages and granulocytes to the impaired capillary endothelium. I already showed you that through lipocortin, the steroids block the production of arachidonic acid from the phospholipids. Steroids also block the activation of bradykinin, a strong vasodilator that affects the release of numerous other inflammatory mediators. And so the overall effect of glucocorticoids is to reduce the activity of the innate and acquired immune systems. And if this is then prolonged, in fact, it also can decrease healing and decreases the protective aspects of the inflammatory process. So remember that the reason why we have these inflammatory cascades is really to protect our body. But it also has negative reactions. Inflammation can be prolonged, and therefore, in fact, glucocorticoids may help. On the other hand, though, if we impede this natural inflammatory processes, there can also be a decrease in the healing process. So these are the cellular effects of glucocorticoids. Like I said, it's a drop in everything, no? Decrease eosinophils, decrease in basophils, but on the other hand, there's an increase in your neutrophils. There's also an inhibition of the secretion of interleukin-1. So again, just to show you, not only a decrease in number, but greater apoptosis of the eosinophils, decrease in cytokine production, decrease in mast cells, decrease in the number of dendritic cells, but on the other hand, a greater number of neutrophils. And if you take a look at the structural cells, like the epithelial cells, there's also a decrease in the cytokines and mediators of inflammation. There's a decrease in leak in the interstitium. And in the airway smooth muscle, there's a decrease in action of the beta-2 receptors, decreasing also the cellular swelling in your airway smooth muscle, and a decrease in mucus secretion. Okay, so we're dealing with glucocorticoids. And glucocorticoids, like I said, have metabolic effects. But it's not just on glucose. It's also on protein, lipid, and bone and mineral metabolism. So if you take a look at the effect on carbohydrate metabolism, these are effects that tend to bring up your blood sugar or hyperglycemia. And in the long run, if prolonged, can even lead to type 2 diabetes. So what are these processes? There's a decrease in uptake and utilization of the peripheral tissues, such as the muscle, and the decrease in uptake of the muscle, uptake of glucose by the muscle. There's an increase in glycogenolysis or glycogen breakdown in the muscle and even in the liver, and increased hepatic gluconeogenesis. On the other hand, there's increased protein catabolism and decreased protein synthesis. And what is typically sacrificed here is the muscle, leading to atrophy and weakness. There's again a permissive effect on the lipolytic hormones, leading to redistribution of fat in the central part of the body, in the axial part of the body, the face, the shoulder, the supraclavicular area, the back, and the abdominal area. There's also decreased osteoblast formation and activity versus an increase in osteoclast activity, coupled with a decreased conversion of vitamin D to active vitamin D and a decrease, therefore, of calcium absorption from the gut, all of which can lead to osteoporosis. So these are the abnormal effects if you give steroids for a long period of time in high doses, or if you have an increase in endogenous secretion of steroids. These are the metabolic effects that can happen. So the effect on skeletal muscle is because of a decrease in cellular transfer of amino acids, coupled with a simultaneous increase in elimination through the blood circulation, leading to a decrease in muscle mass, leading to atrophy, such as what is seen in Cushing's syndrome. And this protein catabolism is most exaggerated for the fluorinated derivatives that I pointed out earlier, because of the presence in some muscles of cytoplasmic receptors that have greater affinity for the fluorinated derivatives than the other steroid derivatives. So this is beta-metasone, dexamethasone, and triamcinolone. So this is a graphic of someone with Cushing's syndrome. Cushing's syndrome is typically an increase in cortisol, hypercortisolemia, as a result of a benign tumor in your pituitary that oversecretes ACTH, or in your adrenal gland that oversecretes cortisol. So when cortisol is high, what can happen? It has some psychological or psychiatric effects, such as euphoria. There is this fat deposition in the central part of the body, so that you have moon phases, a buffalo hump, increased abdominal fat. And on the other hand, there's muscle atrophy. There's a decrease in collagen synthesis, so there is a thinning of the skin and easy bruisability. Also poor wound healing, And because of the breakdown in the collagen in the subcutaneous, you actually have this violaceous striae. And they're violaceous because you can see the capillary networks under the skin. There's also a tendency for osteoporosis, to high sugar, and increased susceptibility to infection. The effects of glucocorticoids in the adipose tissue, like I said, is really to redistribute the fat to the viscera and centrally. On connective tissue and bone, prolonged administration of glucocorticoids will lead to atrophy of the connective tissue, osteoporosis in adults, and arrested growth in children, which is completely reversible once the steroids are discontinued. The catabolic effects, I've talked about that already, having to do with an increase in action of the osteoclast coupled with decreased bone synthesis and the reduced calcium absorption with an increase in urinary calcium loss would also lead to secondary compensatory hyperparathyroidism. And all of these effects could possibly lead to osteoporosis. So there's a decreased bone formation, a decrease in renal calcium reabsorption, decrease in calcium absorption from the gut, decrease in sex hormone secretion, all of which can lead to increased bone resorption, increased remodeling, and subsequently osteoporosis. So just to summarize then, what we've talked about in terms of the effects of long-term use or a long-term effect of having very high cortisol levels, whether endogenous or exogenous. You can have these effects on glucose, leading to hyperglycemia. You have these effects also on your adipose, on your lipids, so that you have hyperlipidemia. You will have reduced cellular amino acid uptake, leading to impaired protein synthesis, decreased fibroblast laying down, impairment of collagen synthesis, which is seen as impairment of wound healing, skin thinning, and vascular fragility, and even peptic ulcer perforation. This, coupled with the problems of increased osteoclast activity, decreased osteoblast laying down, and decreased calcium absorption, would lead to osteoporosis. So we'll end with that because in the next part, we will now talk about the pharmacologic preparations of glucocorticoids. We'll talk about briefly their structure and what accounts for why some of these glucocorticoids have stronger anti-inflammatory activity than others. And we'll talk about both their therapeutic effects and uses, as well as the adverse effects and their mitigation. So this ends part 1. And this is mainly a review of physiology and some of the other learnings that you might already have had in LU3.